So Kara, so you know, there are not only individuals signing on, but there are people in rooms with lots of, like the EUH, the residents are mostly in EUH room and Midtown room and Grady room and the VA and so on. So you have some of these squares represent crowds and some of them are individuals.
Super. Can't wait to hear what everyone thinks.
I think I will go ahead and launch us so as not to take time away. So I'm really delighted to welcome you all to Medicine Grand Rounds here for the last Grand Rounds of September. And we are thrilled to have as our guest, Dr. Kara Pepper. Dr. Pepper is a practicing primary care internist and certified life coach here in Atlanta, who rebuilt her life and career after burnout. And I think that is a talk I really want to hear you give at some point. But today is not that day for everyone, but we will happily invite her back. Her telemedicine clinical practice serves adults across the Southeast, especially those with eating disorders. And that's going to be the topic of our discussion today. She does use forward-facing evidence-based coaching to help high-achieving perfectionists through burnout and career transition. She provides one-on-one and group coaching, leads retreats, and speaks on topics surrounding burnout, perfectionism, imposter syndrome, wellness, and career transition. But today we are going to learn about managing adults with eating disorder. And so, Dr. Pepper, thank you so much for joining us. And I'm anxious to learn something new.
Thank you very much for that warm welcome. I'm going to pull up my slides before we get started. Well, hi. Thank you for having me. Kara Pepper. I'm coming to you from my basement in Midtown, so right there in the midst of Atlanta with y'all. Long before I was a physician, I was a professional ballet dancer. And for those of you who don't know, professional ballet dancers and doctors are the same people. We're lifelong learners. We show up at work every day to get better and better at what we do. Lots of perfectionism, lots of workaholism. And so it could have been the pack of cigarettes I started smoking every day at 13 or the Diet Coke I was living on, but I kept breaking things during my dance career. And so ultimately, after about 3 years professional work, I had to figure out what to do with my life. So obviously I went to med school. It was a pretty easy transition because again, different skill set, but same personalities. I brought all my perfectionism and workaholism with me and did great med school and residency and joined a practice of largely chief residents. But not surprisingly to anyone who knew me, I worked myself into a place of burnout where I literally could not get out of bed anymore. And so I took a sabbatical and kind of rebuilt my life and found coaching in the meantime. But in the midst of all that, I had developed this following of folks with eating disorders. What I told myself at the time was just that I was a really good doctor and I was a good listener and good at putting together pieces of the puzzle. But really, I understood their brains because not surprisingly, I was nearly 40 and finally reconciled my own behavior with eating disorders. And so it really is the case in point that what is considered normal in our society around weight management, our relationship with our bodies, food and exercise, makes it very easy to hide some of these behaviors, whether it's restricting food, overeating food, purging food, over-exercising. And so often we think of this as a young person's disease, but here we are taking care of grown adults, which is where the lion's share of eating disorders find themselves. So today I just wanted to talk about what that looks like in our clinics. And as I was preparing for this talk, I could have spent the entire hour talking about the fascination of refeeding syndrome and hypermetabolic states after people start to feed. But the truth is, we're not even making the diagnosis. And so the best effort that we can have for our patients is really to see them as whole people and to really create safe space for these conversations to happen and to make the diagnosis to begin with so that we can treat the medical complications. The thing that I really love about eating disorder care is, one, it draws on exactly who we are as internists. Like, we are problem solvers. We love to put together pieces of the puzzle for a living. And so eating disorders show up with multi-system disease symptoms. And so having that intuition to look at all the different pieces of the puzzle is really critical. We're taught about the great mimickers like HIV and tuberculosis and lupus, Lyme disease. If you see that answer on the board of your question, that's the answer. So eating disorders very much are the same way. They can show up in any organ system in the body and lie dormant for many, many years before we recognize what's going on. So you have to be a good internist, take care of eating disorder folks. Secondly, it really is at the center of the social justice movement. Largely marginalized populations are disproportionately impacted by eating disorder behaviors, and they go without treatment. And so we owe it to our patients to identify them. And then lastly, medicine is pretty lonely sometimes. And so eating disorder care is a multidisciplinary delivery of care between therapists, medical providers, and registered dietitians. And so it's really fun. Like, I get to talk to people about patients in a way that in the silo of my private practice, I don't typically do. So anyway, I hope my not so secret ambition is that Emory's going to fall in love with eating disorders and want to start a center of excellence here. But at a minimum, I hope that you can see these patients as whole people and start to identify them. This is my obligatory CME slide. We're going to talk about how to identify these folks, what our own internalized biases are and why we don't recognize them, and how to add eating disorders to every one of our differentials. So before we get started, just by show of hands, you can do it electronically or otherwise, or send me a note in the chat. PS, feel free to use the chat throughout this entire thing. You can send me private messages. I'll be happy to answer the questions at the end, or you can send public messages. So who feels comfortable screening for eating disorder behavior and managing these folks? Like, I want to know who you are so we can chat after this. I'm hopeful to see one hand or more, and not surprisingly, one. Hey, Holly, yay, thank you. Yay, good, super. Secondly, if you want to just close your eyes and check in, when you think of someone with an eating disorder, what do they look like? Picture them sitting in the exam room with you. What are their genders? What color is their skin? How old are they? What are their behaviors? What do they look like? We are trained to recognize patterns. And what I would like to disrupt for you today is that the pattern of eating disorder behavior that we're taught is not actually what it looks like in clinical practice. And then lastly, when you think about getting on the scale in the doctor's office, which is predominantly in the hallway or in a public place, what is your personal reaction to that experience? Do you celebrate it? You're like, yes, can't wait to get on the scale. You dread it? Do you bring like flip-flops so you can like not have your heavy shoes on? Or is it just neutral, like brushing your teeth, like no mind drama over it, just a thing you do? If you are a patient who is already terrified to show up in a doctor's office and you had to have that experience, what might that be like for you? All right, we're gonna start at the beginning, like to really just look at how we came to think the way that we think about body size and shape. This is a very abbreviated history, but the BMI was first developed back in the 1830s by a Belgian astronomer by the name of Adolf Quetelet. Basically took a bunch of French and Scottish men. So at that time, without refrigeration, there were unstable food supplies. They were largely laborers. They were all white Northern European men, and just plotted them on a bell curve and found out what was, quote, normal for body size. And he came up with the formula that we now know as the BMI. Basically, nothing happened with that medically speaking, except for eugenics, which is another talk. But the use of the BMI and the broad spectrum like we have now really didn't begin until the 1970s. Ansel Keys basically said, how do we tell how much adiposity our patients have? So he compared BMI to calipers, which is where you pinch the skin and measure adiposity, and body density, like underwater weighing. Basically, the BMI was the best of the worst. It really only predicted adiposity about 60% of the time, 60, 65%. And of note, the people that he looked at, again, were all men from the United States, Finland, Italy, Japan, and South Africa. And the Bantu men from South Africa actually were outliers in this BMI metric. And so he just excluded them from his data and reported just the white men and the men from Japan. We didn't really use the BMI clinically until about the 80s, but in the 90s, the International Obesity Task Force, who PS, their principal funders were the two companies who manufactured Fen-Phen and Redux, adopted the BMI, and instead of using 27.5 like it was recommended for overweight, moved that metric down to 25. So overnight with their recommendations, millions of Americans then were qualified as overweight and therefore able to access the medications for weight loss. So in subsequent studies, I'll summarize it by this. The BMI basically overestimates adiposity in Blacks, underestimates it in Asian folks, and definitely does not correlate well for females, and particularly across the age spectrum. So do I think the BMI is going away? No, it is well baked into every research trial we have. It's clearly related to how we get reimbursed and the metrics that we have to report in every clinical encounter. But it's worth knowing, number one, if people are already having a lot of shame about their behaviors, their body size, and their failure to meet our quote standards, are those standards appropriate for the patients that you personally are taking care of in your clinic? And what do we believe about the BMI? I'm not arguing that body size and shape has anything to do with hemodynamics and body mechanics. We know that. But it may not be consistent with our patients' values and what is possible for them based on who they are. So this is why I really think eating disorder care falls in the middle of the social justice movements, right? Because our patients are not men from the 1830s. So let's start with like, what is normal? And we'll work our way through the eating disorder spectrum. So normal eating, which we all have, is regulated by physiology. We get hungry, we satiate our hunger. We eat until we're feeling full and then we stop. We have hunger cues. We eat for fun because it tastes good and because it helps us feel socially connected. Taking a step away from that to disordered eating, this is not a DSM criteria, but it's when we start to override that natural process. So when we start skipping meals, this is often glamorized with intermittent fasting, dieting, which we'll talk about in a little bit, grazing on snack foods. If you've ever had someone say, hey, you should eat 5 meals a day to increase your metabolism. So we're kind of overriding our natural hunger drive, or just simply an imbalance. We're just not eating enough to supply our body with the fuel that it really needs. So this is imparted in us at a very young age. And these types of behaviors increase our risk for true eating disorders. Eating disorders, the very short summary is that they are psychiatric, emotional, and mental health diseases that have compensatory behaviors that drive medical problems. So our colleagues in psychiatry are seeing these folks, but they don't necessarily manage the downstream effects of that. And we often see symptoms medically, but we're not looking for the root cause. So there's this big gap in between where eating disorder behaviors fall through. And it's really just a complex relationship that's maladaptive between our food, our bodies, and our exercise, and our body image. So this is the summary slide just on eating disorders. We'll talk about cases in a minute. The DSM-5 criteria are over here on the left. So anorexia is effectively calorie restriction. There's two different kind of subsets, one where you purely restrict and the other where it's associated with binging and or purging. It's highly associated with a fear of weight gain and a denial that the weight loss is causing any issues. Bulimia is emotional regulation with eating and then purging, and or sometimes people simply purge even if there's nothing in their system. So it's a purge disorder. So purging can be emesis, but also over-exercising, misuse of insulin, use of laxative diuretics, anything to get rid of extra calories for the purpose of weight loss. By comparison, binge eating disorder is episodic overeating to a point of discomfort, which causes shame. ARFID, avoided and restrictive food intake disorder, we often don't see in the adult world. These folks are generally picked up in the pediatric clinics because it causes growth and developmental issues, highly associated with neurodevelopmental disorders. You can think of them in terms of like picky eating or sensory processing disorders, texture disorders, swallowing disorders. Frankly, I don't see a lot of these folks in my clinic. And then this is like the NOS category. They don't quite meet the criteria for the other ones, but there's clearly criteria that are close. And over here, I just put these here because this is often what we see and gets glamorized in society. So compulsive overeating is more just like overeating, not episodically, but throughout the day. as opposed to the episodic binge eating disorder. Prader-Willi obviously is a genetic disorder, but it's associated with increased hunger drive. It's insatiable, so there's compulsive overeating that happens there. Diabulimia is the misuse of insulin for the purposes of weight loss. So 1/3 of type 1 diabetics practice diabulimia, particularly in their teens and 20s. So if you're taking care of type 1 diabetics, they need to be screened. Orthorexia, oh, I just like cut out gluten and dairy and I'm exercising all the time. And we put that very publicly in the social eye as if this is the metric of health. But the rigidity around that, the compulsion around that, and the kind of obsessive behavior is what makes it very similar to some of the DSM-5 criteria. Drunkorexia, this is also not DSM-5, but this is a very insidious one that we see so commonly that no one ever names. It's like, oh, I just had a stressful week. I'm just going to open a bottle of wine. And you know what? I just don't feel like making dinner. I'm like, oops, I just didn't eat and I drank instead. So it's the substitution of drinking instead of eating. And so it's a way that often it kind of flies under the radar where we don't really recognize that. We'll talk about substance abuse in a little bit. And then lastly, progorexia, any life change, but particularly something that's going to impact your body size or shape, like pregnancy, will trigger some eating disorder behaviors. And so augmenting weight gain during pregnancy, in other words, not gaining sufficient weight in order for the purposes of weight loss can be a clue for that. So these are the ones that we often see, and these are the ones that have a diagnosis. But the bottom line is it's a spectrum of disorders. And so when you're seeing people cope with the mental and emotional or psychiatric stress with rigidity, compulsive behavior, shame around food, diet, and exercise, and their body image, like that's a clue that there's something going on. Okay, if you know someone who has an eating disorder, they're highly associated with mental health disorders, like I mentioned. So about 80% of folks, 90% of folks have diagnosable depression, a little less, but significant amount have anxiety. OCD is super common, particularly around the intrusive thoughts and rigidity around behaviors. About half of people have comorbid substance abuse. I mentioned drugorexia earlier, but all of these are ways to escape feelings of discomfort. Trauma, the data is across the board from 30 to 90%, but I personally find that it's ubiquitous in the populations that I take care of. And so you cannot take care of eating disorder folks without practicing trauma-informed care. And so understanding that that is a big piece of their behaviors is really important. And of course, PTSD is there as well. And then for those of y'all in specialty clinics, if you have patients with POTS, about 75% of them have eating disorder behaviors, they need to be screened. About 20% of all comers in a GI clinic have eating disorder behaviors, but about half of people with IBS. So just like think about, you're like bloated, somatic, nausea, vomiting, diarrhea, constipation patients that we're trying to manage. About half of them have eating disorder behaviors underlying that. About a third of folks have addiction, and I mentioned earlier about a third of type 1 diabetics struggle with misuse of insulin for weight management. So if you run in these clinics, please be sure to screen. We'll talk about that. So I asked you earlier about pattern recognition, really, which is like, what do you picture when you think of eating disorder folks? If you picture any patterns, like these are some of the diseases that run kind of in the same circles as eating disorders. So POTS, I mentioned earlier, postural orthostatic tachycardia syndrome, SIBO and gastric motility disorders, Ehlers-Danlos and hypermobility. There's a connective tissue autoimmune component that we're finding is related to that, which is how MALS, mast cell activation syndrome, MCAS, sorry, shows up in that. And then MALS is I'll talk about it in a minute, but it's chronic abdominal pain due to hypermobility. And then long COVID has been thrown into this. So I'm not here to explain the mechanism of all of that, but if you're looking for patterns for folks who tend to like run in these circles, eating disorders are highly prominent. That's the take-home message. Okay. Why am I spending so much time talking about this? Because I want you to see the patients that you're seeing in your clinic today and recognize them as having these behaviors. So we often think of eating disorders as being adolescent and young adults. And while yes, that's when we start to see a peak of it, about half of people with eating disorder behaviors never recover. And so that long tail that we're seeing into our internal medicine clinics is there for a reason. It's not like we get our Medicare card and suddenly our body dysmorphia goes away, right? It really is there and needs to be addressed. So young and old folks. We often think of women, and yes, women are disproportionately affected by eating disorder behavior, often because of the cultural messaging around thinness being worthiness. But by the time young girls reach elementary school, first through third grade, about 40% of them are already thinking that they need to be thin in order to be worthy. By the time they're 10, 80% of girls are thinking that they're afraid of being fat. And so they're already starting to think of ways to manage their weight. So about 40% of 10-year-olds are dieting at this point. And by the time young women reach college, about 90% of women have tried at least one diet in their lifetime. It's not just a problem for women. For all comers, for men, about 5% exhibit eating disorder behavior in their lifetime, often more in the binge category, binge and purge, less likely restriction, but it's still there. And that's for heterosexual cis hetero men. But in the gay community, for cis gay men, about 15% exhibit eating disorder behavior. I'll talk about that in a second. For people of color, they are less likely to be asked about eating disorder behavior and therefore diagnosed with eating disorders. And therefore they end up having longer term, more protracted illness. So their chances of recovery are lower. Black teens are 50% more to have bulimia compared to their white counterparts. The same goes in the Hispanic community. Asian populations typically have more restrictive behavior, but not always. And so disproportionately, we're seeing increased rates in people of color. In the LGBTQ community, gay men are 7 times more likely to be binging and 12 times more likely to purge. Particularly in the trans community, eating disorder behaviors to augment body image and deal with gender dysphoria is a big deal. So about a third of folks by the time they're in their early 20s are using eating disorder behavior to augment their body size and shape. And trans college kids are about 4 times more likely to have eating disorder. So when I talk about social justice, like this is what I mean. These are real people trying to make their way through this very stressful life that we have. And when people don't feel good, they find ways to feel better, and eating disorder behavior can be part of that. So why are we missing this diagnosis? If like everyone, young and old, gay, straight, black, white, all across the board, we're seeing this, number one, there's a ton of healthcare trauma. And so a lot of folks just simply don't want to come to the doctor. So they're flying under the radar and managing their symptoms at home. Secondly, when they show up in our office, go back, before they even show up, when they call our office, what is that experience like? Are we asking about pronouns? Are we asking about their names that they want us to use? Are we asking about things that are irrelevant in our intake process? When they show up in our office, what's the first thing we typically do, which is like put them on a scale? Generally, that's going to be in a hallway or a cubby that's pretty public. And so lots of people don't even want to get on the scale, so they avoid coming in. And then let's picture like your typical like type 2 diabetic in their 40s who came in and maybe they've lost 10 pounds since their last visit. Like, what do we say to them? Congratulations, I see you lost 10 pounds. That's great. And to dig underneath the surface to say, like, why did that actually happen? That's often what we don't make time to do. And so we inappropriately affirm weight loss, even though that may be a manifestation of eating disorder behavior. Or we recommend like, hey, you've got hypertension, you've got a chronic medical issue, you should just diet, exercise, and weight loss. And though I haven't said it yet, eating disorders are the most lethal mental health disorder. Actually, the caveat is that with a pandemic, now opioid overdose has surpassed that. But after that, eating disorders are the most lethal diagnosis in the psychiatric community. So the same way as when we had a patient come in and they've got diabetes and proteinuria, and we think about putting them on an ACE inhibitor, but they've had anaphylaxis, we'd say, okay, we can't do that. Let's find another way to manage your problem. Or if you've got chronic kidney disease, if you're creatinine of 2, we won't say, oh, just take all the NSAIDs you want. We'd say, let's find another way to manage that. We see you as a whole patient and we want to make sure we're making appropriate recommendations. I have a patient with symptomatic anemia who came in with a hemoglobin of 5, and she's a Jehovah's Witness. So I wouldn't be like, you know what, you just have to take blood because that's what we do. No, we'd find another way around that. And so what feels so casual to us to say, hey, you should just like diet, exercise, and weight loss, it can literally be a life-threatening recommendation to our patients if we don't know what we're doing. And yet we don't ask. So it's time to start doing that. We need to screen. One comment before we move to cases. If you've ever seen these cards, it really is a means of advocacy for patients to say, I don't want to get on the scale. That for me is very activating, and it creates a lot of trauma for me. So you may see these cards. Please don't weigh me without my consent. Please let me know why you think that is relevant. There are a handful of reasons why I personally continue to weigh patients. That may be in pediatric birth and development. It may be perioperative management and you need weight-based medications. If I have a patient with heart failure and I'm managing volume status, pregnancy, of course. But if you really think about most of what we do in the internal medicine world, we don't need weights. We are trained to think we need weights, but do you really? And so if you truly need it, if it's really going to make a difference in your management, it's worth discussing that with your patients. One of the things that I personally use is this device called My ClearStep. I have no financial connection to them. I just happen to like their product. This is a numberless scale. So if I need the weight, particularly as I'm 100% telemedicine, this is a Bluetooth activated device that sends me the number that the patient never actually has to see. So you are allowed to get blind weights after discussing with your patients if that is in a way that makes more sense and is less provocative for your patients. And then lastly, one of the ways that we create weight inclusive trauma-informed environments for our patients is to have actual medical devices that work for the size and shape of the patient in front of us. So we need more than just 2 sizes in blood pressure cuffs. Patients come in all different shapes and sizes. One of the most affirming things that we can do is have medical gowns that actually fit our patients in a variety of shapes and sizes. And this is just a personal PSA. If you're using this white cape thing, that for really thin women, their boobs hang out the side. And if you're in a larger body, you know, it looks like a Britney Spears top. Like, it's time to just let these things go. They're terrible. No one likes them. So having appropriate medical chairs, tables, and instruments so that we can treat our patients respectfully is really important. Okay, let's talk about cases. So picture a 32-year-old trans man who comes in at a referral from cardiology. He's had some near syncope and night sweats. Saw his mom's cardiologist, labs, EKG, echo were normal. He takes some basic vitals when they get in. Clearly he's orthostatic. So what do you think when you hear this? Now, I know you guys are amazing internists and you're already thinking about like cancer diagnoses and crazy infectious diseases. We're talking about eating disorders, so you know that those are not the diagnoses here, right? So what might be driving this in the eating disorder world, right? We'll do the appropriate internal medicine workup. But when you ask him, like, tell me about these night sweats, like how long has that been going on? Tell me about that. Like, yeah, it's usually pretty predictable. It's usually like 3 or 4 in the morning. Anything make them better? Yeah, if I eat a little something, it gets better. Ever happen during the day? Yeah, if I skip meals, that'll happen. But I try not to do that. All right, well, tell me what you ate yesterday. Okay, like a salad. Okay, tell me what your salad is. It's like 2 pieces of lettuce. Okay, great. Anything else on there? Yeah, like 5 almonds. 5, yeah. Okay, good. So that's a salad, 5 almonds and 2 pieces of lettuce. Yes. How long have you been, experiencing these symptoms? How long have you been tweaking your skipping meals or eating like that? Well, actually, I've had a ton of body image issues, and I learned pretty early on that if I just restrict my diet, that it reduces the curves of my chest and my hips, and that actually makes me feel a lot better. So it's actually something I've been doing for a while, but it's just starting to catch up with me now. Well, I can see that I really think this is from hypoglycemia. What would it be like for you to consider eating on a regular basis? Yeah, I'm not quite sure that that's going to happen. So the take-home point from this, the thing that actually in our burned out condition of practicing medicine is that it would be much easier to just send this guy for like CT scans and like say come back in 3 months. The amount of history, which is our basic, most essential tool in medicine, requires scratching beneath the surface to make these diagnoses. So he clearly has anorexia, which is not eating enough in order to maintain what he needs for his body to work. It's characterized by this real fear of weight gain and a denial that this is actually a problem. And so although I'm going to talk about heart stuff in just a second, this night sweat, the hypoglycemia, is a life-threatening, foreboding, red flag symptom in anorexia. We'll talk about how people die, but hypoglycemia is a big, big problem. It's important. I just want you to like commit this to memory. Amenorrhea and BMI are not a criteria for making the diagnosis of anorexia. So you can have people in any size or shape body. In fact, I have patients who are, well over 250 pounds who literally eat virtually nothing. And they've been dieting and restricting for so long that they don't actually lose weight anymore. They live in a larger body, but they are very clearly anorexic. 20% of people have lifelong disease, 50% relapse, like I mentioned earlier. But if you're waiting for the waif-like person to walk into your office, you're going to miss them because only 6% of people with anorexia have a low BMI. I just want to say that again, 94% of people with anorexia have normal to elevated BMIs. This slide on purpose has a million words. You don't have to read them. The point of the slide is anorexia and chronic malnutrition have affected every organ system in our body. You can pick your organ of choice, the one you love taking care of, and take a peek. But basically, when I say that this is a mimicry kind of disease, it's because you may have all these different symptoms that when you put them together, you can recognize as malnourishment. The number one cause of death in anorexia is death by suicide. Unfortunately, about a third of folks who die is death by suicide. The next cause, the next medical cause after that, is sudden cardiac death. When you follow these folks on telemetry, they go into PEA arrest from hypoglycemia. So when I mentioned that hypoglycemia is a big effing deal, that's what I mean. We often see like sugars of like 74, and you're like, oh, it's just fine. You're just probably fasting. Like, no, that's a huge problem. Because no matter what the size or shape of your body is, if you cannot perform gluconeogenesis and you're having night sweats overnight, or you're having symptomatic hypoglycemia during the day, it is a big problem. Our vital organs need glucose, and we underestimate our body's ability to keep up with that. Heart failure from cardiac atrophy, transient mitral valve prolapse, all bradycardia, it's not because they're super athletes. It can be because the heart literally cannot keep up with the pumping that it needs, and so downregulates. So heart-related issues are a big concern with chronic restrictors. The two organ systems that have the longest term impacts from chronic restriction, the first is the GI system. I mentioned earlier about 20% of all comers in the GI clinic have eating disorder behavior, about a third of folks with IBS. But anyone who's got a functional GI issue, motility disorder, if you're seeing unexplained hepatitis from autophagia of the liver cells, or chronic unexplained abdominal pain, it's an instant cue to think about eating disorder behavior. Refeeding pancreatitis is also a big deal, especially when we start feeding people who are virtually eating nothing. And this is one of the life-threatening acute care symptoms that we see. Two comments about chronic abdominal pain that go misdiagnosed. So SMA syndrome, superior mesenteric artery syndrome. Here's the SMA. There's a fat pad that lies underneath that supports the duodenum from being squished. As people lose weight, no matter what the size of their body is, that can shrink and it squishes the duodenum. So they end up with abdominal pain, small bowel obstruction kind of symptoms. And so the treatment for this is weight restoration. Sometimes people need J tubes to bypass this in order to create the weight gain. But if you're thinking of chronic abdominal pain, can't quite figure out why, this is something to keep on your differential. MALS, median arcuate ligament syndrome, is in the family of Ehlers-Danlos diseases. There's this ligament that goes from the spine around the aorta and overpasses the celiac plexus. And so it gets floppy, for lack of a better word, and starts to kind of hang and impinge on the celiac artery and the nerve. So you may have not just abdominal pain, but abdominal anginal type of symptoms. And when we screen them, we don't actually see any atherosclerotic plaque, so we can't quite figure it out. But it's a mechanical problem. And the definitive treatment actually is surgery to like tack this guy back up. But there's only one guy up in New England who does that surgery. The celiac plexus of nerves, I actually had some success with treating with gabapentin to treat this as neuropathic pain, and patients actually get better. So if you're looking for chronic abdominal pain symptoms and can't quite figure it out, like gabapentin may be your friend. And then the second organ system with long-lasting complications is our bones, like our endocrine system. I mentioned hypoglycemia earlier. Bone loss is super common. And so every patient ends up with a DEXA, male or female. Not all bone loss is menopausal, of course. And then infertility is also super common, even after people weight restore. Weight restoration is the treatment of choice for all of this. And then there is some emerging data, not putting people on birth control pills, but low dose estrogen patches can be helpful for bone density. All right, next case. So a 36-year-old African-American cis woman who comes in for metabolic syndrome follow-up. She's got an ACE, adverse childhood experience score of 4. And you've been talking about medication with her and she really just doesn't want to do that. So we ask her, like, tell me about how you feel your body. P.S. I don't ask about calories or macros. Tell me about how you feel your body. Tell me what you ate yesterday. Or actually, you know, I had a really stressful day and I didn't feel like cooking, so I just went through the drive-thru on my way home. And I know you tell me I'm not supposed to eat that kind of stuff, but I just didn't have time. I normally do my shopping at Dollar General because there's not a grocery store near me. Like, okay, so what did you order? Just a couple of things. Tell me what that actually looks like. I got like 4 number 3s. Okay, great. How did you feel after that? Actually, I felt really bad. So I just kind of got rid of it. How long have you been getting rid of the food that you're eating? Well, actually, I had this thing that happened as a kid that I don't really like to talk about, but my grandmother was always my safe space. And so she would always feed me when things got bad. And I recognized that I was getting a lot of attention from people that I didn't want. But as I went through my teenage years, I gained weight and that attention actually decreased. And so, although I didn't really like being a big girl, it really helped me feel safe in my body because people stopped paying attention to me. And now I'm really terrified that I'm going to end up with diabetes and lose my leg. And so I have a lot of shame around that, but I just can't. It actually doesn't feel safe to be in a small body for me anymore. And so this patient who's binging and then she, quote, gets rid of it, it's worth getting granular about what that actually means. But in her case, she's purging. So this is a woman with bulimia. She's having these binge purge episodes. She's really worried about her weight. It's not just purging because she's uncomfortable. It's I'm purging because I feel so bad about me, who I am, and the shame that I have around this behavior. As I mentioned earlier, it's not just emesis, laxatives, diuretics, overexercising, and insulin misuse are part of that. This is actually one of my patients. It's a panoramic X-ray taken at the age of 23. So you can see that she's already got tons of crowns and dental implants. And she's since had $80,000 worth of dental repair. This is 23. So often we actually get referrals from the ENT and dental community for bulimia. So pay attention to that. There's a cycle often that people are emotionally regulating with this binge purge cycle. Oops. I mentioned that the guilt and shame and frustration. So she's worried about weight gain. So she tries to restrict during the day. She's not eating much at work, but then she's hungry. Maybe she doesn't have access to food or food is really expensive these days. So then she eats things that she doesn't want to eat, binges, and then feels really bad about it. She's kind of stuck in this cycle. And so as all of us can imagine, we have a patient coming in for diabetes, and it's such a knee-jerk reaction. We're like, oh, you should just lose weight and exercise and cut out carbs, right? But for her, if we don't ask, we don't know that she's got eating disorder behavior, but more specifically, what we're recommending is something that does not feel safe and will not be achievable for her. We have totally ignored her lived experience of what it means to have these behaviors and why they have been serving her for all this time. And so prescribing more insulin is not going to fix this issue, right? All right, last case. 44-year-old guy who comes in. He's got diabetes, A1C is 8.6. He's on a bunch of meds. He's like, I know, doc, I haven't lost weight. I just like to eat. So tell me about that. How long have you liked to eat? We all like to eat. Well, I used to play football in college and, we'd have these big parties. I could eat like 2 pizzas by myself. But, since I don't play professionally, I have an adult job, I'm adulting. And it just feels good. I'm stressed out at the end of the week. And it's just what I do. Just get together with friends and we just eat. My wife makes these amazing casseroles. Okay, great. Tell me about what that's like for you specifically. Before you actually put the first bite in your mouth, what is that like? And I'll be like, you know what? I just want to turn my brain off. I feel like I'm just so stressed out. And once I start to eat, it's just it numbs me. I don't think about things anymore. I can finally relax when that happens. Do you ever make yourself sick? I don't feel great. I feel bloated and gross, but I don't necessarily purge. This one time I did because I just ate way too much. So this is classic binge eating disorder, right? He's eating more than he wants. He's typically doing it when he's alone at the end of the week. They may feel disgusted, kind of lots of shame around that. And there can be a lot of distress from that, but it's not necessarily the the purge part that qualifies it. It's just this overeating, and it's episodic. Once a week for 3 months is the diagnostic criteria. Okay, so how do you know that these patients who are definitely in your clinics right now or in your hospital service, how do you identify them, right? I have yet to have a person come and say, hey, just want to let you know I have an eating disorder. And P.S., if they do, they have done a ton of work to get to a place in recovery where they're comfortable saying that out loud. So how do we do it? We ask. Okay, this is the practical application part of the talk, right? So the SCOFF questionnaire is the one they use in research trials, SCOFF, SCOFF. So do you make yourself sick because you feel uncomfortably full? This gets to the purge part or the overeating part. Do you worry you've lost control over how much you eat? That can be either I feel the need to control, I am eating and I don't have control over that, etc. You lost more than 1 stone, which is 14 pounds in a 3-month period. So rapid weight loss, a pound a week. Do you believe yourself to be fat when others say you're too thin? That's body dysmorphia commentary. And then would you say that food dominates your life? So 2 out of 5 has a high degree of sensitivity and specificity. Honestly, I think these questions are a little cumbersome. They're not the ones that I particularly use, but if I want to be like really clear about it, I will. These are the questions I find a little more helpful, which is one like, do you worry about gaining weight? If you ask my husband, he'd be like, that happens. He doesn't have an eating disorder. For people who are worried about they have body dysmorphia, they have gender dysphoria, they are overeating, or they're really, really worried about weight gain, like you'll know in how they answer this question, either by total avoidance of the question or lots and lots of words to answer it. How much time do you spend thinking about your body, food, and exercise? It's not unusual for people to spend 80-90% of their waking hours just thinking about how are they going to eat, who are they going to eat with, how are they not going to eat, how are they going to hide their purging, what if someone comes over, what if they get asked out to dinner and a social engagement. It becomes all encompassing. You ever overeat and feel like it's impossible to stop? Everyone on this call has overeaten in their lifetime, but the impossibility part really gets to the binge, like I'm just eating and numbing my brain. And then the real money question is like, what do you get out of that? Like, how is that benefiting you? Because people are not doing this because they want to have a lethal mental health disorder. They're doing it because it's fixing something for them. And that's where you can really get to what might be underlying. And that's where we actually get our treatment here. So what do? So you have this patient, you're kind of worried about it. Maybe they've like given you some clues. Maybe you're seeing things in their physical symptoms that you're worried about. So first is just like we take an HBI on chest pain, you can ask about their behaviors. So what do you ask? What specifically are you doing? Tell me about what you ate yesterday. How much did you move your body? What does that look like? Are you using laxatives, diuretics? Tell me about your insulin. How long has this been going on? So the longer it's been going on, the more support they're going to need to get over it. And then obviously severity, purging once every 3 months is very different than purging 10 times a day. And so get a sense about what that looks like. So ask about their specific behaviors, get some data. So we're going to do some orthostatic vitals. These are the typical labs I get, particularly in restrictors. DEXAs on everyone who have restrictive eating disorder behavior, and an EKG. Now, there is nothing more gaslighting for a patient who's finally saying, hey, I need some help. For us as a medical community to be like, but your BMI is over 20 and your labs are fine, therefore you're fine. Normal labs do not mean that everything's okay. It is behaviors that determine the level of care that people need. So our bodies are amazing at homeostasis. They are designed to keep us alive. They've made it through all types of feast and famine. Normal labs do not mean that patients are okay. Normal labs do not mean that patients are okay. They're behaviors that really matter. So where do you send these people? I don't expect you to know how to manage complex eating disorders, but what we can do is ask for help. So just as a frame of reference, there are multiple different levels of care for folks who are struggling. So outpatient would be like the entry level. They're just seeing a therapist, a dietitian, medical provider. These are people who are stable, who are working in recovery and managing behaviors. For those who are still struggling to keep up with their meal plans, who are still purging, who are still engaging, in intensive outpatient program, IOP, is more support. It's like 3 hours most days out of the week. They have individual and group. They have meal support where they actually have to eat in front of other people, which can be very proactive or activating, but it gives a little bit more intensive treatment. Partial hospitalization programs, PHPs, are basically a full-time job. You kind of go there instead of you go to work. These people need FMLA. It's definitely much more intensive in structure than IOP. And for folks who are still having behaviors outside of that 8-hour window, residential treatment, which you go and live basically in an apartment or a group home, have 24-hour a day intensive treatment is helpful. And then for folks who are medically unstable, who need telemetry, are at high risk for refeeding syndrome, they need tubes, they need daily labs, that's inpatient. Now, to be clear, inpatient is not what we think about inpatient, like going to a hospital like Emory. There is only one hospital in America who has an inpatient floor for folks who have chronic restriction, severe malnutrition. It's called Acute. It's in Denver, Colorado. So When I say I'm admitting a patient for inpatient treatment, it's more like a facility, it's like a nursing home, long hallway, multiple rooms, and 24-hour-a-day medical providers on staff. There are no inpatient facilities in Georgia. What do we have? These are the resources here in Atlanta. There's a number of facilities. They treat adolescents very well. They all have IOPs and PHPs. But for our sickest patients, if you're under the age of 24, you can access residential care here at Veritas. Walden has 5 beds. So PS, 5 beds for the entire state of Georgia. And if we need inpatient care, if you're under the age of 24, you can go to Veritas, or you can go to CHOA up to your 21st birthday. But for my patients who are largely over this age range, like, I have to send them out of state. And so with eating disorders and mental health crisis that we're in, eating disorder admissions have doubled in the past 2 years. So if you have someone who's hemodynamically unstable, it is super fun to wait like 3 weeks for a bed. So we definitely need more resources here. Okay, if you've forgotten all of that, this is the place that you need to go. The International Association of Eating Disorder Professionals. They have an Atlanta chapter, Atlanta IADEP. You can go to the search bar at the top, find an expert, and it will give you a list of all the dietitians, nutritionists, medical providers that take care of these folks. Ironically, my name is not on this list, but we're sorting that. The website hasn't been updated. In addition, you can click on this thing. It's a downloadable PDF that your patients can access and that you can access. You can have it at your touchdown station, and it has every provider that's in there, and it has detailed information about every eating disorder. It's awesome. It's a great, great resource. So how do we put all this together? We and our patients need time and space and a functioning healthcare system that allows us to take care of our patients as whole people, so that we can create weight-inclusive, trauma-informed environments that people desire to seek their care in. The next is to ask yourself, does this patient really need to be weighed today? And if you're having that visceral feeling of like, but Kara, that's what we do, just pay attention to what that might be. What has influenced that idea? And is it really true? Do not recommend diet, exercise, weight loss without screening for eating disorder behavior. I'm aware, as the most recent data that came out last week on burnout, that 62% of physicians are burned out at this point. Asking you to do more screening, particularly in a primary care clinic, is a big ask. I hear you. I've been doing it. I know it's hard. Our patients deserve it. And then lastly, no matter what your patient is coming in for, ask yourself, could this be eating disorder behavior showing up? And then lastly, don't be afraid to ask for help. There's a ton of us here in Atlanta who do this work, and we really love it. And we will help you triage. If you can't figure out where the patient's supposed to go, just send them to one of us. We'll help you figure it out. Totally fine. Last quote. Eating disorders like diastolic murmurs, gotta assume every patient has one. Go listen for it. When you don't hear it, assume you missed it and go listen again. I'm happy to answer any questions. Thank you for having me. It's really a pleasure to be back with you all.
Thank you so much. So everybody, please feel free to put some questions in the chat. Let me open up questions by thanking you first off for helping us recognize this clearly under-recognized problems. Do you find that patients have awareness of their illness and that your heightened awareness facilitates treatment?
Eating disorders thrive in shame and secrecy. And so I find that most people know that there's a problem, but they absolutely do not want to talk about it. It's the coping strategy. It's kind of like a frenemy that's been around for a long time. And so to disclose that takes a lot of self-awareness and trust. And then there is, ironically, then there is a ton of denial associated with that as well. I think my story is illustrative of that, that it's just like a normalized behavior that we don't understand how fully that's impacting us. So it's a little bit of both.
Yeah, no, I'm actually getting messages from people saying, I wonder how many patients we're missing in our insert like care setting here.
Yeah.
Are there, like you mentioned that there are not a lot of inpatient resources in the area. How about, do you have recommendations to support patients to connect and follow through with care? Or is that another area where there's, sort of internalized stigma that may prevent people from wanting to follow through with that?
Are you asking if we have a functioning healthcare system that has a high degree of mental health resources for our patients? Um, it's challenging. It really is. And because these patients require time and patience to get an adequate history, they don't fit well into a 15-minute time slot. And so the intensity of the teams that treat them oftentimes are cash pay because they've gone off insurance plans so they can give patients the time that they need. And so that further puts a gap between people who really need care and people who can access it. There are certainly people here in Atlanta who take insurance. All of the residential IOP, PHP programs, they take insurance, which is great, but the individual outpatient providers don't always do that. So part of that resource guide that I gave you, I think that there are some comments about what insurance people take in there. It's a challenge is the short answer.
Yeah, no, unfortunately, you're right about the opening part of your comment about a functioning healthcare system. Question that I received, can you speak a little bit more about the older adult and eating disorders? And are there differences in what you look for, any clinical pearls for that population?
Yeah, that's a great question. So because these are adaptive behaviors to psychological, emotional, mental stress. So any big change, particularly in the geriatric population, changing residences, changing, health, like a big life-threatening health event, any divorces, spousal death, et cetera, like all of those things can trigger old, indolent behaviors. I would encourage anyone who's managing hyponatremia, we call it like the tea and toast diet. It's not like this cute term, like it may literally be that your patient is eating tea and toast and they're not actually eating. So it's a big clue that there may be restrictive eating disorder behavior in the background. All weight loss is not due to malignancy and medications, right? Some of it can be because people are intentionally restricting their diet. And I find that, although eating disorder behavior often starts in the young adolescent, teen, early adult years, it can go into remission, but we may see some of that uptick later on in life with some of these stressors. So you may have patients who are like, yeah, no, I've been totally fine. I never got treated for eating disorder, but now these behaviors are starting to crop back in. So the easiest way to know is just to ask.
Great, thanks. Shanti, Dr. Srinivasan, do you want to unmute and ask your question?
Sure. So thank you, Kara. That was a wonderful talk. I have you mentioned intermittent fasting in the beginning of the talk, and it is, I'm just wondering, does that lead to long-term eating disorders? Do you, for some people, it really works as a strategy for weight loss if they really need to lose some weight for medical reasons. So I was just curious what your thoughts are on that.
The short answer is it depends, right? And so the part that we don't spend a lot of time assessing is like, what does that do to the patient's brain? So there's some people who are just like, yeah, just like skip a meal. I have this 8-16 plan and, it's no big deal. And I feel great and mentally clear. The question to patients that I ask is like, how much time do you spend thinking about this? What is that bringing up for you? How does that change your relationship with your body? Are you feeling really rigid about it? And sometimes that is really the clue into that, where it crosses the line from something that may truly be helping with medical issues to something that's branched into like an obsessive, life-altering state. And so that's the tricky part. We don't often have that rapid follow-up to like come back and do a psychiatric exam on our patients that we've recommended diabetes management for, but that's the space that we're missing. So it depends on the person. Some people can tolerate it fine, others really cannot.
Thank you.
You're welcome.
All right. Anyone else want to unmute and ask a question? I think we are pretty close to the top of the hour.
I have one more comment. I should have mentioned in the beginning, but it's not lost on me that plenty of high functioning, anxious and depressed people show up in medicine and are spending their lives taking care of other folks. And so I know that there's probably someone on this call right now who's struggling with eating disorder behavior. And to you, I say, you don't have to suffer like this anymore. Life is so much better on the other side. So we're here when you're ready.
I have one question, and that is the patient, once you are treating them, can they recognize this as a pattern of behavior so that they recognize that this is the way they respond to stress? And does this realization help?
It can, I think it takes a while to get to that place of insight, to connect the dots. And it's, as I mentioned, the behaviors are really serving people. They may create psychological safety for folks. So even if they're like, yes, intellectually, I know that I need to eat, and I know that actually my brain feels better when I eat, it feels so terrifying because it brings up my history of trauma. It brings up feelings of insecurity or food insecurity in my home of origin. And so that's the piece where therapy is really helpful and necessary to fully get into recovery, because it's not about knowing often, it's about what is the actual response, the emotional response we're having. It's like telling an alcoholic, well, you just stop drinking and it'll be fine. Well, yeah, it's going to bring up all the reasons that they were drinking to begin with. So filling that gap with therapy is really important.
Well, thank you so much. And thank you for your sort of PSA at the end, speaking to this group that's listening to you. And I really appreciate you joining us today. This has been, I think, a topic that we don't talk about much in adult medicine. And it's our pediatric and med peds colleagues who are much smarter about this, but I think so important for us to have on the front of our minds.
Thank you for having me. It's great to be back home at Emory. I appreciate it.
We're thrilled to have you back.
All right, I'll hang back and answer questions if anyone has them, but thank you. Y'all have a good day. Thanks for all you do. Hi, Holly. I'm so glad to meet you.
I'm so glad to finally get to connect with you, and I saw you on the Grand Round schedule.